السلام عليكم جميعا. طبعا الاسابيع الجايه راح نبدا بالسيستمز اكزامينيشن اللي هي كارديوفاسكولار ريسبيراتوري جي اي نيورو. الشيء الكويس في المواضيع هذه انها البيسكس حقتها والخطوط العريضه كامله نفس الادلت اكزامينيشن، نفس الميديسن. فهذا راح يساعدكم، ما راح تكون نيو ماتيريال. هدفنا في السيشنز راح يكون التركيز على الاشياء المختلفه في البيدياتريكس عن الادلتس. what do you think that in cardiovascular examination is different between adults and pediatrics? What are the major things that will make your cardiovascular examination, if you're going to examine a child, will be different than if you examine the cardiovascular system in an adult? عادل وش قصدك بالمكان؟ هل يختلف site of the heart في البيدياتريكس عن الادلت؟ ليه كيف يختلف؟ ترى البقيه انتظر منكم تشاركون. Yeah, but it doesn't make a big difference in terms of physical examination. In terms of the size and site. The sites of auscultation in adult is the same as the sites of auscultation in pediatrics. Doesn't really make a difference. But what are the other differences? This is a very good Abdurrahman Hamid Subhi. In pediatrics, you see a lot of congenital heart diseases. This is a major one. So congenital heart disease is a big portion of your cardiovascular examination with pediatrics, and you should be oriented to the presentation and signs and symptoms of different congenital heart diseases. The majority of the patient that you will see because of congenital heart diseases. I had a big difference. For adults, it's mostly acquired heart diseases, which have a different presentation. But this is a big one. The other one, معتز الغامدي صح, heart rate. So the other thing is that the vital signs are different. In terms of heart rate or blood pressure, we have a different normals for both heart rate and blood pressure. For adults تقريبا it's one theme. تعرف الهارت rate normal, and it will apply to all adults. نفس الشيء blood pressure, you would know what is the normal for blood pressure and it would apply to all adults. In pediatrics, different age groups will have different normals. But you should be aware of this. What's considered as a normal heart rate for a neonate will be tachycardia for a 10-year-old. So this is a big difference. The capillary refill time is the same. Capillary refill time is the same for adult for pediatrics. So it's not, there's no difference. The other thing that you have to pay attention to is the cooperation. A big difference if you're gonna examine a pediatric patient versus an adult is the cooperation. For adult, you could ask them to take a deep breath, hold the breath, to have a certain position, to stay quiet. في البيدياتريك ما راح يكون هذا الشيء ممكن في كثير من الأحيان. They will be crying, they will not be cooperative with you. صحيح؟ But you have to adjust your physical examination to use you have to be opportunistic. تستغل بعض الفرص إنك تسوي certain examination areas while they are cooperating with you, so you could use the other time to examine other parts. But it's very important once you examine a pediatric patient that you come with this in your mind. فهذه الأشياء الثانية congenital heart disease, as you said, will variable heart rate and blood pressure with age. Okay. بنخلي شوي هذا الجنرال اكزامينيشن في فيديو اتمنى انه يشتغل كويس معنا، راح نشغله بعدين نرجع مرة ثانية.
Hi, versus benign murmurs.
Clinical history.
هل الصوت واضح عندكم؟
From a history standpoint, there are three important categories: gestational and perinatal history, especially if evaluating an infant, postnatal and present history, and then family history. We're going to go through each of these. The gestational and perinatal history is really important when evaluating an infant. Specifically, you're going to want to ask about the maternal history. Were they healthy while they were pregnant? Did they receive prenatal care? And did they have regular ultrasounds during pregnancy? And if so, did those show anything of concern? When you're asking about maternal infections, you're referring mostly to the torch infections, but any infection is also important to note. Finally, you're going to ask if mom took any medications. Specifically, phenytoin, lithium, retinoic acid, and warfarin have all been associated with cardiac malformations. The postnatal and present history is our next category. Most importantly for infants and young children is, are they growing along their growth curve? And if they're not growing along their growth curve, have they at least continued to consistently gain weight, or have they been losing weight? Are they meeting their developmental milestones? Have there been any feeding problems? Is there any cyanosis? Decreased exercise tolerance. Specifically for young children, you're going to want to ask, as they run around on the playground, are they able to keep up with their peers, or are they falling back? Have they ever fainted or felt as if they were about to faint? Have they ever experienced chest pain or palpitations? When you're asking about palpitations, I usually pose the question to children, have they had any extra beats or skipped beats? The most important thing to remember when evaluating an infant is that feeding is really an exercise test for them. And if they are able to feed and grow, there's usually not a major cardiac issue. Family history. You're going to want to ask if anyone has ever been born with a heart problem, and that'll be your screening for family history of congenital heart disease. Has anyone passed away suddenly or from an unexplained cause? Often I will also ask about unexplained car accidents or drownings because those can be indicative of electrical problems with the heart. Does anyone have hypertrophic or dilated cardiomyopathy? And does anyone in the family require a pacemaker or an implanted defibrillator?
Clinical exam.
Next, we're going to move to the physical exam. The most important thing when you walk in the room is to take in the general appearance of the infant or child. From a nutritional standpoint, do they look well-nourished or are they malnourished? And in terms of their respiratory status, are they breathing easily or are they breathing quickly and with difficulty? Then you're going to turn to palpation from the cardiac perspective. You're going to put your hand on their chest and feel their precordium to see if they are hyperdynamic. Is the point of maximal impulse displaced? And do you feel a thrill? Then you're going to turn to peripheral pulses. In an infant, it's going to be really important to feel for the upper brachial pulse and the lower femoral pulses. And note, are they bounding or is there a difference between the upper and lower pulses? In addition, you're going to want to, at this point, turn to the blood pressure, which should in an infant or young child have been taken in both an upper extremity and a lower one to make sure that there's no gradient.
Point of clarification. A systolic blood pressure measurement of greater than 10 millimeters of mercury higher in the arm than the leg may signify the presence of a coarctation of the aorta.
Then you're going to turn to auscultation. Auscultation refers to the appreciation of the heart sounds. It's important to remember that there are two big heart sounds, S1 and S2. S1 is going to refer to the mitral and tricuspid valve closure, and S2 to the aortic and pulmonary valve closure. People often talk about the splitting of S2. In normal children, it is normal to hear a variation in the splitting with respiration.
Abnormal heart sounds.
Abnormal splitting refers to when the S2 sounds are widely split, and that can be reflective of volume overload or electrical delay in a right bundle branch block. Narrowly split second heart sounds usually are reflective of pulmonary hypertension or aortic stenosis. And if the second heart sound is entirely single, that is reflective of severe aortic stenosis or pulmonary hypertension. This is a useful diagram for referring to the different areas that you'll listen to the valves opening and closing. As you can see, there is an appropriate place to listen for both the mitral, the tricuspid, and then the aortic and the pulmonic.
Murmurs.
Murmurs are the sound of blood moving through the heart. It's important to remember that those can be benign and the sound of blood moving through an entirely structurally normal heart, or the sound made by blood moving through abnormal valves or holes in the heart. Murmurs are broken down into systolic, diastolic, continuous, gallops, and clicks. We will go through each of these. Before we do that, it's important to remember that we grade murmurs and that we are standardized across all specialties into how we grade the murmurs. Grade 1 is barely audible. Grade 2 is soft but easily audible. A grade 3 is moderately loud, but accompanied by no thrill when you put your hand on the precordium. Grade 4 is loud and has a thrill. Grade 5 is audible with a stethoscope barely on the chest, and grade 6 is audible with a stethoscope off the chest, and very rare. Systolic murmurs are divided into 3 categories: ejection, late systolic, and holosystolic. Ejection murmurs are usually reflective of pulmonary stenosis or aortic stenosis. Late systolic murmurs are usually reflective of mitral valve prolapse, and holosystolic murmurs are usually tricuspid regurgitation, mitral regurgitation, or a ventricular septal defect. This is a helpful chart in terms of breaking down the ways that systolic murmurs sound. In a mid-systolic murmur, you can hear that they're initially softer, then they get louder, and then softer again. Sometimes that's referred to as a crescendo-decrescendo murmur. Holosystolic murmurs are heard throughout systole between S1 and S2, and can often actually obscure the beginning of diastole. Early systolic murmurs are short and heard right at the beginning. And late systolic murmurs are usually reflective of mitral regurgitation and are usually accompanied by a mitral click. Diastolic murmurs are always pathologic. They are broken into early diastolic and mid-diastolic. Early diastolic murmurs are usually higher pitched and are reflective of aortic regurgitation if it radiates to the apex, or pulmonary regurgitation if it radiates along the left sternal border. Mid-diastolic murmurs tend to be lower pitched, are appreciated with the bell of your stethoscope, and are either mitral stenosis, which you hear at the apex of the heart, or tricuspid stenosis at the left lower sternal border. Continuous murmurs are reflective of a PDA, an AV fistula, a shunt murmur after surgery, or a venous hum. PDAs are patent ductus arteriosus murmurs and are usually appreciated in newborns before the duct has closed. In addition, shunt murmurs are usually only heard after a child has had surgery. This is another diagram that is helpful for remembering where you're going to hear each of the murmurs. So an aortic valve stenosis murmur would be best appreciated in the aortic valve area, which is in the right upper sternal border. Pulmonic murmurs are usually heard along the left upper sternal border. Mitral murmurs are usually heard along the apex, and a VSD or tricuspid regurgitation or Stills murmurs are heard at the left lower sternal border.
Gallops.
Gallops are broken down into either S3 or S4. The third heart sound is referred to as S3 and is usually heard at the apex of the heart.
Point of clarification. An S3 gallop is best heard at the apex if produced by a dilated or dysfunctional left ventricle, or along the left lower sternal border if produced by a dilated or dysfunctional right ventricle.
It can be normal in children and young adults, although it can also be reflective of patients with dilated ventricles and decreased compliance. Fourth heart sounds are heard also at the apex, and these are always pathologic.
Point of clarification. An S4 gallop is usually associated with decreased ventricular compliance that occurs with myocardial ischemia or ventricular hypertrophy. Clicks.
Clicks. There are 3 types of clicks: ejection click, mid-systolic click, or the diastolic opening snap. An ejection click is usually appreciated at the apex of the heart and is reflective of aortic stenosis, usually if there's a bicuspid aortic valve as well. Mid-systolic clicks are heard at the apex and usually reflect mitral valve prolapse. Finally, diastolic opening snaps are also mitral stenosis, but are usually heard at the apex or left lower sternal border.
Rubs. A pericardial friction rub can be heard when the two walls of the pericardium rub against each other, producing audible friction. This sound can be described as a grating, scratching, or rasping noise that sounds similar to squeaky leather. It has both a systolic and diastolic component and often obscures the normal S1 and S2 heart sounds. The sound is usually best heard between the apex and the sternum and can be indicative of pericarditis, which is an inflammation of the fibrous sac surrounding the heart.
Thank you very much for your time today. I hope that you've enjoyed learning about the cardiac history.
هل في أسئلة على الفيديو؟ طبعا التفاصيل الكليكس والراب والاشياء هذه يعني ما راح تكون موضوع اختبار في السايكل هذه، بس it is for your knowledge. very good. اتوقع انه شرحها بطريقه كويسه. ما هو مطلوب منكم التفاصيل بس it's good for you to hear them، تعرفون وش انواعها للتسهيل. نادرا تلقى فيديو يحتوي على كل هذه التفاصيل بالشرح هذا، بالتصوير هذا، بالفويسز، بالساوندز الموجوده قصدي. ف this is a very helpful فيديو. راح يفيدكم حتى لو ان شاء الله راح ارسلكم كل الفيديوهات. في بعض النقاط البسيطة راح نغطيها بس to complete ال physical examination components. زي ما قلنا once you try general physical examination زي ما قلنا قبل، for any system you have to start with the general assessment of the patient. Part of the general assessment with cardiovascular is, are there any dysmorphic features? Any dysmorphic feature that would suggest any syndrome that is known to be associated with congenital heart disease. هل هو مثلا واضح عليه dysmorphic features of trisomy 21 اللي هو داون syndrome؟ هل هو في features of Turner syndrome؟ لأنه بتعطيك hint إنه this patient may have AVSD, may have coarctation and so on. بعدين لازم قبل ما نبدأ زي ما قلنا دائما نبدأ بالvital signs. الvital signs تعطيك a hint of how well or how ill the child is. تقدر تاخذ راحتك في الفيزيكال examination ولا لا يحتاج تسوي quick assessment and start intervention. فالvital signs are always important. وpart of the general examination is to get the growth parameters. يا إما إنك تاخذها من الشارت أو إنك تسويها بنفسك. بعد ما تخلص من general physical examination تبدأ بال more focused examination. الهارت ريت زي ما قلنا it varies with the age. شرحنا في المحاضرة الماضية الساينس الريثميا إنه الهارت ريت يتغير مع البريدنج. Once you inspire it will be quicker. Once you expire it will slow down. However, persistent tachycardia or bradycardia or any irregular heartbeat other than a sinus arrhythmia should prompt you to investigate to exclude the pathologic arrhythmias. فإذا شفت abnormally tachycardic ممكن تكون SVT. abnormally bradycardia ممكن تكون prolonged QT syndrome أو congenital heart block. فكلها تحتاج assessment. The blood pressure should be taken in all four limbs. الأهم على الأقل one upper and one lower. إذا ما تسوي في الفور limbs at least إن تسوي one upper and one lower عشان تشوف في difference ولا لا. وقلنا إذا في difference of more than 10 millimeters زي في الفيديو this would suggest coarctation. The cuff size has to be adequate. If the cuff is too small, the result will be falsely high. العكس. إذا الكف حقت blood pressure measuring is too small, بيكون falsely high. If it's too large, will be falsely low blood pressure. فهي تمشي بالعكس. واضح؟ عندنا في البيدياتريكس في جداول خاصة what is the normal blood pressure. ما يحتاج تعرفونها، بس عندنا جداول خاصة what we consider as hypertension نعتمد عليها. الهايبوتنشن لها قاعدة راح ناخذها بعدين في واحد من التوتوريالز، فدون worry about it. keep in mind الاكسرسايز، الاكسايتمنت، الكافينج، الكراينج خاصة انه موجود بكثرة في الأطفال الصغار. it may increase the blood pressure. فجاك طفل وهو جالس يبكي، يمكن البلد بريشر بيصير عالي بس بسبب البكاء وانه متضايق من الفيزيكال اكزامينيشن، and which is not true hypertension. الجروث شارتس خلقناها. البالسز زي ما شرحنا قبل في what we call الباوندينج pulse. شرحنا قبل وش ممكن يسبب لك باوندينج pulses. قلنا اي شيء يقلل الديستوليك زي البي زي الاورتيك insufficiency، او احيانا increased cardiac output. The bounding pulses could present in some congenital heart diseases اللي مطلوب منكم تعرفونها اللي هي PDA mainly. Okay. Diminished pulses معناته ضعيفة. Okay. هذه ممكن تكون مع أي ضعف لعضلة القلب زي البريكارديال تمبونات، left ventricular outflow obstruction من ضمنها الكونكتيشن، أو cardiomyopathy. وزي ما تعرفون أكيد radio femoral delay will be seen في ال aortic coarctation. السيانوسز best observed clinically بالnail beds أو اللبز والتنك والميوكس membranes. يا إما إنك تشوفه بالnail beds، والأفضل إنك تشوفه في اللبس والتنك جوا، ما تشوفه برا على ال around the mouth. ليش؟ بنجيبها شوي. Clubbing of the fingers and toes is not usually manifested until late in the first year of life. طبعا أي cyanotic congenital heart disease, if it's not treated, they will have clubbing. أي واحد عنده decreased oxygen saturation long term, they will have clubbing of the fingers and toes, but it would not be clinically manifested unless after 1 year of age. But it needs to be for a long period of time. في شيء نسميه differential cyanosis. وش معنى differential؟ يعني ما هو كلهم عندهم cyanosis، مو كل الجسم فيه cyanosis. It will be manifested as a blue lower extremities and pink upper extremities. والpink usually اللي هو right arm. فلو تجيب pulse oximeter تحسب الأكسجين saturation، إذا حطيته بالرايت arm الساتوريشن بيكون عالي، تيجي تحطه بالlower limb تلقى الساتوريشن نازل. This is seen with right to left shunt across the PDA in the presence of coarctation. فأي واحد عنده coarctation they will have differential cyanosis. واضح؟ الأنواع الثانية للسيانوسز اللي ما هي سنترال. السنترال سيانوسز هذا اللي نهتم به. أوكي؟ السنترال سيانوسز إنه يكون عنده سيانوسز بالتنك في الميوكس ممبرينز. في شيء يسميه سيركم أورال سيانوسز، يعني حوالين الأورال كافيتي، حوالين الفم. هذه خاصة بالنيونيت could be normal. ليش؟ لأن عندهم venous plexus in these areas، يا إما سيركم أورال أو أحيانا بالفورهيد، حتى في الجبهة تصير مزرقة شوي، أو حوالين الفم برا مكان الشنب. أوكي؟ تكون لونها على أزرق. هذه ما هي سينوسز، هي بس venous plexus، لأنه السكن يصير thin فتكون بينة على أزرق. بس لما تقيس عندهم الأكسجين saturation تلقاه طبيعي. هاي نسميها circumoral cyanosis، وهذا في الغالب بالنيونيتس في اليونج infants. The extremities of infants often turn blue when the infant is unwrapped and cold. هاي نسميها acrocyanosis. acro معناها أطراف البريفريز، فالacrocyanosis معناته blueness of the peripheries. This condition can be distinguished from central cyanosis by examination of the tongue and mucous membranes. اذا جيت لقيت اليدين مزرقه شوي على زراق، ممكن هذا احيانا خاصه بالانفنت ممكن يكون due to الكولد ويذر. فلازم تفحص التنج والميوكس membranes inside the mouth. If they are pink فمعناته ان هذا acrocyanosis not a true cyanosis اللي هو central cyanosis، وهذا طبيعي. زي ما قلنا signs of heart failure في الغالب يصير عندهم هيباتوميجالي اكثر من البريفرال إديمة. احيانا اذا طول ممكن نسوي لهم سبلينوميجالي، بس الاهم هو الهيباتوميجالي. البريفرال إديمة are age dependent. And keep in mind the infants they're lying all the time. تمام؟ فالإديمة is usually seen around the eyes أو الفلانكس الأجناب حقتهم. Okay? older children and teenagers ممكن يصير عندهم periorbital and pedal edema زي بالadults. But it is not uncommon initially compliant in these older patients that their clothes no longer fit. لأنهم إذا زادت السوائل عندهم خاصة إذا جاك واحد قال مثلا والله الأهل قالوا إنه الحذاء وأنت بكرامة قاعد يغير السايز بسرعة، هذا you should think is there an edema عشان كذا قاعدة تضيق عليه الشوز. If you hear this complaint, keep in mind, is this a sign of peripheral edema? The pericardium examination will rest of the examination was well explained بالفيديو. طبعا في وقت ما نخلص طبعا السيستمز بتمشي بالشكل هذا. طبعا الكلاسز الجايه بتكون mainly بالهوسبيتال. هذا فضلت انه يكون هنا لان الفيديو اللي فيه اصوات وهذه افضل يكون واحد على الجهاز يسمع الاصوات حقت الميرمرز اوضح له. الباقي 3 سيستمز بتكون كلها في الهوسبيتال. اللي بعدها زي ما قلنا بتكون approach to different diseases، بناخذ clinical scenarios بتكون mainly الهيستوري تيكينج. هذه بتكون مقسمين على الجروبات وراح نسوي simulation. أنا باخذ دور أب ولا أم وأعطيكم history وأسألكم إيش الأشياء المهمة في الهيستوري، how to differentiate between the different diseases. هذه كلها بالنصف الثاني اللي بعد الاختبار. وقبل الاختبار بيكون فيه طبعا الله أعلم إلى الآن اللي يبدو لي لا ما في المستشفى شيء. إذا تغير شيء طبعا من التوجيهات العليا يعني إنه يفتحوا الموضوع أكثر ممكن يكون فيه، بس إلى الآن لا. راح نكمل على البراكتيكال سيشنز بالجامعة. بعدين طبعا بيكون في سيشنز أنا بجيب المانيكن بختار منكم كم شخص. مثلا بيقول والله تعال يا يوسف demonstrate how you will do a cardiovascular examination. تعال يا عادل الشمري demonstrate how you do a GI system examination. فهذه كل الأشياء بنسويها. I will see your techniques and I will comment on your technique. واضح؟ أنا عارف أنا والله أتمنى إنك تروح المستشفى يا حسن، بس هذا ما هو عن طريقي أنا صراحة، هذا عن طريق الكلية. الكلية هي اللي تقرر أنك تروح المستشفى أو لا. أنا أتمنى والله المستشفى أفضل بكثير، بس في restrictions كثيرة في المستشفيات. أتوقع أنه بيكون في صعوبة أنكم ترجعون المستشفى في الفترة هذه، لأن نفس المستشفيات أصلاً عندهم صعوبة في تقبل طلابهم. يعني أنا أشوف عندنا في جامعة الملك سعود إحنا we limited الclinical sessions. يعني من زمان كانوا ياخذون حوالي 40 سيشن، الآن الحين يمكن ياخذون في الهوسبيتال 4 فقط. فإحنا we limited الclinical sessions for our own students. أتوقع نفس الشيء صاير مع المستشفيات الثانية، بيكون صعب إنهم يتقبلونكم، لكن هذا القرار ما هو بيدي. القرار هذا على الليفل حقت الكلية وإدارة الكلية، هي اللي تتناقش ومع المستشفيات. ولا أنا أتمنى صراحة أنكم تروحوا المستشفى دائما وأبدا، يعني ما في شيء يعدل أنك تشوف a real patient in terms of physical examination. لكن احنا بنحاول قدر الإمكان أننا نغطي النقص قدر الإمكان.